This is Dr. Heidi Silver at the Vanderbilt University Medical Center, where I am a research professor and director of the Vanderbilt Diet, Body Composition, and Human Metabolism Core. My presentation is limited to 15 minutes of speaking, so I will pause on some slides to allow you more time with each of those slides. I have no disclosures to reveal, and there was no funding for this presentation. I want you to notice two individuals who have the same BMI. They are obese, and they have a high degree of subcutaneous fat, which you see in the aqua blue color on the outer sides of the abdomen. What you also see is a significant degree of visceral fat in yellow surrounding the abdominal organs in both individuals. But the individual on the right, who is the same sex, age, and BMI, has much more infiltration of fat, or what we call ectopic fat, invading the skeletal muscle. So I want to distinguish between the state of sarcopenia in obesity and the state of myosteatosis in obesity. Where in sarcopenia, we have atrophy of muscle that affects the quantity, but also the quality with regard to strength, power, and function, leading to impaired physical performance. In myosteatosis, we have substantial amounts of fat infiltrating the skeletal muscle between muscle fibers and muscle bundles, and we also have lipid droplets within the cells themselves. To further distinguish phenotypes, I want to compare the percent of body fat, which you see on the x-axis, with the amount of muscle mass, which you see on the y-axis, to identify different phenotypes, both in the state of normal weight and in the state of obesity. Now here you see one individual who has moved from obese to sarcopenic obese in the course of 1 year. And what you see here is much greater infiltration of fat in the skeletal muscle, more atrophy of the skeletal muscle, and a greater invasion of visceral fat in the abdominal cavity. And in fact, here's another individual where I've quantified the degree to which the atrophy of muscle has occurred. And so you can see in a 2-year period, we've now lost 20% of the total abdominal muscle area. It's important to note that this is not just happening in the abdomen, that total abdominal muscle area in the abdomen is highly correlated with whole body skeletal muscle. So this is a progressive loss of muscle throughout the entire body occurring. Now in this slide, I present to you that this condition of sarcopenic obesity is highly prevalent in all patient populations today. So regardless of whether you are seeing patients or clients in any setting, whether it's in a hospital, in a clinic, in a private practice, in a community environment, this is a highly prevalent condition. And you see that here in a variety of surgical patients who've had resections of different organs, some for malignancy, some for benign disease. You see it in a whole variety of medical patient populations, and I have just a few presented here. And we see it in community residing individuals, even in long-term care in our older adults who we often think of as being underweight and frail. We now see a much greater proportion of obesity and sarcopenic obesity. So here we see a 4 or 5% higher rate of complications like wound breakdown and infections, higher rate of ICU admissions, and higher rate of readmissions to the hospital in individuals who have both sarcopenia and obesity compared to those who have obesity without sarcopenia. And now when we look at the combined condition of sarcopenia and myosteatosis, we see there is a greater likelihood, even when we compare it to visceral obesity, which we know is highly prevalent. We've seen that in increased waist circumferences of all different types of individuals and patients across our populations. But look at how strongly the effect of sarcopenia and myosteatotic obesity is for increased hospital stays, ICU stays, major complications, readmissions, and discharges to nursing homes as opposed to the home environment due to the impact on physical function performance and disease. Now, we have observed some differences by sex and by race among individuals who are obese with regard to the prevalence of ectopic fat infiltrating their muscle and the visceral or intra-abdominal compartment. And we do see that the prevalence of this occurring in males, even when matched by BMI and age, is greater than in females. And when we compare race and ethnicity, we see that African Americans tend to have more infiltration of fat in their skeletal muscle than Asians and whites. We don't know precisely why this occurs, but we have to think about this in the context of the evidence that African Americans also have more type 2 diabetes, more heart disease. And so what the impact of these conditions are to those disease states is not entirely clear, but it may be related to the inflammation and effect on immune function and on insulin sensitivity versus insulin resistance. What's interesting here is that I'm showing you the direct relationship between ectopic fat in the muscle and skeletal muscle loss is occurring today even in healthy younger adults. We see it in individuals in their 30s and their 40s and 50s. So we're not just talking about the sarcopenia of aging. Here I have a summary of the clinical consequences that we know currently with regard to these states of sarcopenia and myosteatosis and obesity. And you can see it ranges from the direct effects on muscle strength, power, and function to effects of inflammation and immune suppression, wound breakdown, infections, mortality, and, as I was previously mentioning, the effects on the ability of muscle to utilize insulin and be sensitive to insulin, and therefore the development of metabolic syndrome, prediabetes, and type 2 diabetes. Now, we queried by interview 45 medical providers from a variety of hospital units to see whether there's interest in this problem, awareness of these conditions, diagnosis of these conditions, and interventions or treatments occurring. And what we found is that while there is much interest and recognition, this is considered a newer concept, and practitioners acknowledge that when they see an overweight or obese individual, they don't really consider the specific obesity phenotype and whether, in fact, there might be problems with muscle mass, muscle atrophy, and its effects, or whether there might be nutrient deficiencies or excesses that differ among individuals with obesity. And therefore, it's very rare that medical diagnosis occurs or interventions happen. In this study, there was a comparison of 3 different levels of protein to determine what amount of protein is necessary to maintain muscle mass while providing a deficit of calories for weight loss in obesity. And you can see that just providing the RDA was inadequate, and the best maintenance or decreased loss of muscle mass occurred with 2 times the RDA, 1.6 grams per kilogram of body weight for protein needs during weight loss. Another thing to consider is the type of protein or the source of the amino acids. And here we have 2 studies that investigated the effects of leucine on muscle mass and physical function. And we can see in the top study, there's a difference in the placebo group versus the treatment group in terms of increasing muscle mass and affecting physical function, which was measured by a timed stair climb. In the bottom study, whey protein was used to increase muscle protein synthesis in obese adults, and compared to soy protein and carbohydrate restriction. Another thing to consider is the effect of carbohydrate on maintaining or increasing muscle mass. And here in this study, we see the change in lean body mass when we compare a carbohydrate-restricted group to a control group who had a typical amount of carbohydrate. And so in developing a prescription for weight loss in obesity, not only must we consider the amount and type of protein, but the amount of carbohydrate. And not just the amount of carbohydrate, but also the types of carbohydrates, specifically with regard to the glycemic index, or perhaps the amount of simple sugars in the diet. And here we see a significant effect of loss of visceral fat when we provide a low glycemic diet compared to a high glycemic diet in overweight adults. So I believe that RDs can take the lead in furthering the awareness and intervention of these debilitating conditions. And one way is to recommend the use of body composition analysis tools in persons with obesity and not consider each obese person similar but actually different from another obese individual. RDs ourselves, we can use readily available physical performance tools like hand grip dynamometers to identify patients and clients who have impaired physical function and might have sarcopenia and/or myosteatosis. And we can promote the diagnosis of sarcopenia as a medical condition in order to encourage intervention and treatment. Further, it is our role to incorporate specific diet and exercise interventions to preserve or increase muscle mass and reduce the infiltration of fat in muscle in order to promote better health in individuals who are normal weight, overweight, and obese, and recognize this is occurring in individuals of all ages, all races, ethnicities, across the board. And further consider the types and amounts of macronutrients that will allow preservation or increase of lean muscle mass while weight loss is occurring.